I'm Dr. Mark Lorenzato, and this video is about back pain. There are two videos, one on the analysis and understanding of the causes of back pain, another on the treatment. Why I can put one video about treatment is most back pain has a component of muscle spasm and inflammation with it. This video mostly deals with that. Whether you have primary lumbar strain, which we'll talk about, or if this is an impingement syndrome, a nerve root being compressed, most people end up with muscle spasm of the low back right above the pelvis with intense pain. Non-specific low back pain that is symmetrical like this is called lumbar strain, mostly because physicians don't understand it. It is rather predictable in the sense it's very debilitating. It can come on with a very almost insignificant injury, turning, twisting, picking up something light. And if the person is capable of not doing anything from that point on for the next 24 hours, frequently it will resolve in 2 days or 3 days. But if you keep on working through it, which is what people generally do with their busy life schedules, it tends to be debilitating for 7 to 10 days. There is a possibility that your low back pain is due to something else, like a fracture, an inflammation from an autoimmune disease, or from a bladder infection, a prostate infection, or something more rare, problem with the colon or cancer or something strange. These are much less common than lumbar strain, but by filling out the questionnaire that I've created, it will help us differentiate so we don't miss these other serious causes. This video reviews mostly just lumbar strain, whether it's primary as a result of what we perceive as probably an immune trigger followed by fatigue, or whether it's secondary to favoring one leg or another and the process of an impingement neuropathy, a pinched nerve someplace. Physical exam may or may not be able to be done depending upon how mobile you are. If I can do leg lifts, we'll do this and evaluate how much you can lift your leg if there's a problem and if your hips mobile or not. Lab work can be very beneficial, particularly urinalysis and lab work to see kidneys and liver are functioning well. And usually the way this plays out is we'll treat this with non-steroidal anti-inflammatories, muscle relaxants, occasional use of narcotics, and follow it for some time, and then determine whether we need more lab tests, including x-rays, MRI, and such, unless there's something sort of leading us in the pathway of a specific diagnosis. All the muscle relaxants, and there are many different classes, all cause sedation. They are disruptive in lifestyle in this way, but they can give you enough relief so you don't have to take narcotics and you have more cognitive functioning. Also, they are an adjunct to cold packs on the back to limit inflammation, followed by warm packs or hot heat to promote circulation. So by alternating hot and cold, that gives some benefit. By not over-exercising it, by moving it enough to gently stretch things and improve circulation, progressing into some physical rehab after you get better, you may accelerate your convalescence. If you have an impingement neuropathy, it can be understood through the dermatome pattern and the pattern of innervation of muscles. The mechanics of most bulging discs or herniated discs is between the bony structure of the spinous process. The spine is built on one piece of bone sitting on top of the other with a disc between, sort of as a shock absorbing device. And right in front of this is our spinal cord, and nerve roots come out of the spinal cord exiting at every level. So the nerve roots coming out from L4, 5, and L3, 4 are very frequently places where the vertebral bodies crush down on the disc some, causing the nerve roots to be impinged or damaged. This can happen at other levels as well. Here's a picture of a dermatome. The dermatome patterns, as I said, represent the innervation coming out of the spinal cord as these nerve roots come out, and they will innervate the sensory and the sensory perception of a certain region. So we can see here the L2, L3 region of the right thigh in the schematic is innervated by the two roots that then come together to form part of the sciatic nerve. This is looking from posterior, same idea. Analysis by muscle groups, L2, L3, L4 dominate the flexion of the hip, the lifting forward with the iliopsoas muscle, and L2, L3, L4 are knee extensions and hip adductions or bringing towards the midline. The sensory of L2, 3 is, as I said, in the anterior thigh. L4 innervates the tibialis anterior, so this is the big toe side of the foot. If I have somebody walking their heels across the room, I can see if they're able to elevate their big toe or not. L4 is also the patellar reflex when we hit right below your kneecap and have the knee jerk, so we can see if there's a problem here. Moving the foot up or dorsiflexion of the toes and the hip adductors is L5, and sensory L5 is in the forefoot, midsection of it. S1 is also, by walking on the heels, I can tell because the extensors of the toes allow one, if without S1 one can't do that. The Achilles tendon reflex is easy to check, that's also S1. The peroneus longus and brevis and the muscles of the calf there, the gastrocnemius and soleus, and the gluteus are all S1 innervated. Lacking the push-off when a person walks, their inability to push off, this weakness also is S1 neuropathy. So S1 neuropathies are not that rare either. So you can see either a loss of muscle mass on one side from this or less strength accordingly. So we're not going into treatment of herniated disc other than to say most of it is conservative and it's painful, usually to experience one. The rest is the major part of it, and avoid re-injuring it. They frequently will write a tapered steroid dose, like a Medrol dose pack, a Solumedrol tapering dose or a prednisone tapering dose. And I generally end up getting an MRI if there's a potential that there will be an operation to rule out other causes as well. It depends on economics, of course. X-rays can be beneficial. If they don't show anything, it doesn't mean there are not other problems there, though. So MRIs are far superior. Interpretation of MRIs is something that has to be done by the radiologist or the orthopedic or neurologist. I don't see enough to feel comfortable in interpreting them for you. In the event that you have a bulging disc, we may follow you over some months and begin physical therapy along the way. Your expectation should be 6 to 12 weeks of convalescence. If this is simply lumbar strain, usually a week. It's much, much better. 10 days, it's mostly resolved. And 2 weeks out, people forget about it. In conclusion, we're going to treat your muscle spasm and inflammation that is part of your back pain experience. You may have a bulging disc, a herniated disc. There may be problems with your hip alignment. Many things can cause back pain. Ultimately, because of the complexity, people end up with muscle spasm and inflammation. We've reviewed the medications you can do for this and a strategy for managing it. Thank you.